Assalamu alaikum. I'm Dr. Matiullah Khan. I'm consultant endocrinologist at Shifa International Hospital. Today, the topic of discussion is thyroid in pregnancy, and it is one of the toughest topic of endocrinology, and it is very important to know. So, basically, we will first talk about physiology, the normal physiology, then hyperthyroidism, and followed by hypothyroidism during pregnancy. So there is increased renal iodide clearance, and due to that, the pregnant women will require more iodine as compared to the normal adults. They will require 220 microgram per day. Along with that, the changes in the thyroid physiology in gestation include increase in the total the binding proteins, that is the thyroid binding globulin will increase and albumin will decrease, and this will result in increase in total T4 and total T3. But this increase in total T4 and total T3 is very predictable, and we can use this total T4 as a surrogate marker when we are doing the TFTs that I will discuss later. One important thing is, because of this increase in TBG and reduced albumin, there are free T4 assay issues when we do it by immunoassay. So total T4 will rise from the first trimester onwards, and it will become then constant in the second and third trimester. And this rise is about 1.5 times the non-pregnant range. So we can just say that the total T4 of a pregnant woman, the upper limit is equal to 1.5 times the non-pregnant range upper limit. That means if the total T4 in a non-pregnant is 10, upper limit is 10. So for a pregnant woman, it will be 1.4 or 1.14 or 15, because we have multiplied it by 1.4 or 1.5. Why we are doing this? Because there are issues with the immunoassays. The best immunoassay is electrochemoluminescent immunoassay, LXs, which is used in the top hospitals of Pakistan. And they are very good tests when done outside pregnancy. And outside pregnancy, we do recommend doing free T4. But in pregnancy, this will not have a good result. And this will be very variable, and it may be going down, but actually the patient has a high free T4. It is not recommended to do free T4 in pregnant women. Rather, we should be doing total T4 and then multiplying it by 1.5, the upper limit of normal. I will keep on stressing on this fact because it's very important. Another thyroid physiology change is the increase in HCG that will result in a decrease in TSH concentration. And there is also increased degradation of T4 and T3 by placental type 3 iodinase. So just a summary, there is increased iodide clearance, so increased iodine demand. Binding proteins are increasing, total T4 and total T3 will increase because of this thyroid binding globulin increasing due to estrogen. And HCG increases, that results in increase in the T4 and reduced TSH. And also the degradation is increased. So all these will then lead to increased demand of thyroid hormone. Naturally, the patient will produce more thyroid hormone. But if the patient is a known case of hypothyroidism, so the patient can't produce it, we have to give extra thyroxine to a pregnant woman, that is around 25 to 30% in the first trimester. I will stress upon it later as well. Here you can see the HCG is increasing in the first trimester, especially 8 to 10 weeks. And with this, the TSH is also decreasing, and then it becomes normalized. So the next question is, what is normal TSH during pregnancy? So in 2011, old guidelines, we used to say that a normal TSH, we have talked about T4, now we are talking about TSH. A normal TSH in the first trimester is less than 2.5, and in the second and third trimester, it is less than 3%, less than 3. This is no more true, because this was based on a small data of 5,000 patients. While then after this, we had many meta-analyses of around 51,000 cohort, and the ATA 2017 guidelines revised this upper limit of normal TSH to, the upper limit is 4.0, and the lower limit is 0.1 for a pregnant woman. If you recall, for a normal non-pregnant, the upper limit of TSH is 4.5 and the lower limit is 0.5. So from 0.5 to 4.5 is normal. You just have to reduce it. The upper limit will be reduced by 0.5, which means 4.0 हो जाएगा, or lower limit will be reduced to 0.4 to 0.1. So simply just 0.1 to 4.0 याद रखना है. Let's switch gears to management of hyperthyroidism in pregnancy and preconception. Now, first will be how to diagnose and then how to manage. Again, stressing upon the TSH in the first trimester, lower reference range is reduced by 0.4 and upper reference range is reduced by 0.5, which tells us the range will be 0.1 to 4.0. तो एक सिंपल हमने अगर माइंड में बनाना है, TSH प्रेगनेंसी में 0.1 to 4.0 है और फ्री T4 करवाना नहीं है. टोटल T4 टोटल T3 के जो अपर लिमिट्स है उसको 1.5 से मल्टीप्लाई करके हमें आंसर मिल जाएगा. क्रिस्टल क्लियर ये चीजें होनी चाहिए, तो फिर आगे हम बात आसानी से कर सकते हैं. अगेन एम्फसाइजिंग ऑन द फ्री T4 इम्यूनोएसे वैल्यूज कैन बी मिसलीडिंग ड्यूरिंग प्रेगनेंसी, बिकॉज इस पेशेंट का रियल में ज्यादा फ्री T4 होना चाहिए था और जो इम्यूनोएसे रॉश एलेक्सिस से हुआ है उसमें कम आ रहा है, which means this will be misleading. And free T4 done in Pakistan everywhere is by the best hospitals have this Roche Alexis. We don't have availability of LCMS. So जब LCMS है ही नहीं तो उसके बारे में हम बात नहीं करेंगे. Now when we don't have the direct free T4 LCMS के जरिए इम्यूनोएसे से इनडायरेक्टली फ्री T4 करके वो जो प्रेगनेंसी में गलत आ रहा है, so that's why we should not be doing it. एक चीज अवेलेबल नहीं है, दूसरे को करना नहीं चाहिए, तो तीसरी बात कोई होनी चाहिए, और वो तीसरी बात यही है जो मैं बार बार कह रहा हूं कि T4 and T3 in a pregnant should be multiplied by 1.5 times the upper limit of normal, which means तकरीबन 150%. So rise of 50% occurs. क्यों? क्योंकि ये जो rise है ये फर्स्ट ट्राइमेस्टर में एक बहुत स्टेडी प्रेडिक्टेबल राइज होता है. If you are a fellow endocrine and you want to know more details of it, तो उसमें ये है कि 7 weeks onwards, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, every week there is a rise of 5%. 7 week में 5%, then 10, 15, 20, 25, 30, 35, 40, 45. तो हर वीक के हिसाब से आप बता सकते हो. But generally, if you are medicine resident or GP, just remember 1.4 or 1.5 times the upper limit of normal से multiply कीजिएगा total T4, वो pregnant में normal range आपको पता चल जाएगी. So, causes of thyrotoxicosis in pregnant women and women of childbearing age. So, we know that pregnancy में Graves' disease and transient gestational thyrotoxicosis. These are the two important causes of thyrotoxicosis. Which one is more common? Gestational transient thyrotoxicosis. This is more common, and these patients we do encounter a lot, and we should not be treating them with numercazole or PTU. Okay, so I will just explain this in detail. The common causes of thyrotoxicosis, as we know, in a childbearing age and in pregnant, are Graves' disease, postpartum or sporadic painless thyroiditis, transient gestational thyrotoxicosis, and maybe exogenous excess thyroid hormone. Some uncommon causes are autonomously functioning thyroid nodule or subacute painful thyroiditis. This graph shows the association of HCG with TSH. The HCG will keep on increasing when the patient has more and more hyperemesis. In a severe hyperemesis, there will be very low TSH, and free T4 will also increase in it. This gives us about the definition of transient gestational thyrotoxicosis. So GTT, gestational transient thyrotoxicosis, is a transient thyrotoxicosis which occurs due to high HCG levels. And these high HCG levels occur in twin or higher order gestations in molar pregnancies, and they will basically bind to the TSH receptor and have some thyrotoxic symptoms and signs as well, along with the primary HCG issues. HCG results in nausea, vomiting, hyperemesis. So along with it, the patient will also have some tremors, heat intolerance, and tachycardia, but there will be no goiter, no Graves' eye disease, and you can simply tell the difference. It's obviously very difficult to differentiate between the two, but some differentiating points are: number one, the severity of thyrotoxic symptoms will be more in Graves' disease, but that may be variable because patient may be on some medications. And it will be mild in gestational transient thyrotoxicosis. There will be stigmata of Graves' disease, which may be absent, but usually they are present. The diffuse goiter will be there. There will be ophthalmopathy in Graves' disease, but there will be no stigmata of Graves' disease in gestational thyrotoxicosis. If you talk about the ratio of serum T3 to T4, it will be more than 20:1, while in gestational thyrotoxicosis, it will be less than 20:1. You cannot do a radioactive iodine scan in pregnant women. Therefore, you do the TRAB level. TRAB, TSH receptor antibodies, will be more in Graves' disease, while negative in gestational transient thyrotoxicosis. And GTT, gestational thyrotoxicosis, has symptoms of nausea and vomiting, and it may be severe. Management. One thing to remember is subclinical hyperthyroidism has no complication and does not need any treatment, while there are potential effects of uncontrolled overt Graves' hyperthyroidism in pregnancy, not only of the mother but also of the fetus. Low birth weight, intrauterine growth restriction, severe preeclampsia, prematurity, pregnancy loss, thyroid storm, heart failure, many issues with overt Graves' disease. So that needs to be treated. But you also have to remember that antithyroid drugs, whether that's carbimazole or PTU, have teratogenicity. And obviously, carbimazole has more teratogenicity as compared to PTU. But PTU is not 100% safe. It also has, according to this Korean and this Danish National Registry, they also have some issues. There are cases of the face and neck and urinary congenital issues. While in the methimazole, there will be musculoskeletal and skin and digestive system issues. So PTU, procarbazole, is recommended for the first trimester only because we cannot give it for a long term due to the liver side effect, severe liver injury, and due to that, black box warning is on it. So because of this risk, we just have to give it for the first trimester. And that is the why we give PTU in first trimester, because first trimester is the period of organogenesis, and methimazole, carbimazole results in choanal atresia and aplasia cutis, esophageal atresia, and many other embryopathies. So best would be actually to avoid it, and we will talk about it, how to avoid it. Now, this is the ATA guideline. It clearly shows that pregnant women receiving carbimazole who require antithyroid drugs should be changed to PTU as early as possible. And even at the time of preconception should be changed to PTU. And then in the and continue till 16 weeks. Then after 16 weeks, the PTU can be changed back to numorkazole. So a simple carbimazole to PTU is conversion is 1:10. So this is rough conversion of carbimazole 5 mg will be equal to 50 mg of PTU. Carbimazole 10 mg will be equal to 100 mg of PTU. Now this slide tells us about the advantages and disadvantages of the therapeutic options for women with Graves' disease seeking pregnancy. If a patient comes to us even before pregnancy and asks us about the different options, we should know about all the options and we should discuss about the options. Patient of Graves' disease, known Graves' disease, of a childbearing age should always be counseled about the definitive treatment, because it's very difficult to manage a Graves' disease during pregnancy. One, due to the changes in the TFTs. Number two, due to the side effects of drug on the mother and on the fetus. And also the Graves' disease has its issues and its effects on the mother and fetus. तो सबसे बेस्ट होगा कि कोई डेफिनेटिव थेरेपी हो जाए. डेफिनेटिव थेरेपी के लिए एक बात याद रखें कि रेडियो एक्टिव आयोडीन थेरेपी अगर ऑप्ट की जाए तो उसमें 6 months का एटलीस्ट और गैप होना चाहिए बिफोर प्रेगनेंसी. अगर उन्होंने 2-3 महीनों के अंदर अंदर प्रेग्नेंट होना है तो डेफिनेटिव थेरेपी विल बी सर्जरी ओनली. Every option has its advantage and disadvantage. If you talk about radioactive iodine, giving it has an advantage because it is easier than surgery, reduction in the size, and future relapse is very rare. But the disadvantage will be you will need T4. There will be repeat treatment if may be needed in some cases, in 10% cases. And because of the rising TRAB titers, and this can worsen orbitopathy. And even during pregnancy, there will be raised TRAB, although you have managed the hyperthyroidism, but you have not managed the autoimmunity. This is the advantage of anti-thyroid drug because it is not only acting as a anti-thyroid functionally, but also acting as and also acting on the autoimmunity. And patient becomes euthyroid, and you can increase or decrease or modify the dose. It is very inexpensive. जाहिर है एंटी थायराइड की मेडिकेशन के भी साइड इफेक्ट्स है, बर्थ डिफेक्ट्स भी है, और विड्रॉ करेंगे तो 50 to 70% रिलैप्स भी होंगे. Thyroidectomy is a very good option for someone going for pregnancy because आप जो है वो बहुत आसानी से उनको थायरोक्सिन के ऊपर स्टेबलाइज कर सकेंगे. ऑब्वियसली सर्जरी हैज इट्स ओन इश्यूज, थायरोक्सिन की नीड पड़ेगी, सर्जरी के अपने कॉम्प्लिकेशंस है, एंड पेशेंट का फेयर एंड ऑल दैट. Just a slide on the TRAB, the TSH receptor antibody titers after RAI surgery or medical therapy. Here you can see RAI therapy में एकदम से बहुत ज़्यादा बढ़ जाता है. And you need कि ये 6 महीने कम से कम गुजरे और फिर उसके बाद जो है वो we go for pregnancy. Because एक तो TRAB बढ़ेगा बहुत ज़्यादा, उसके साथ साथ रेडियोएक्टिव आयोडीन के अपने मसाइल है for the pregnant woman. So इसलिए 6 months का गैप ज़रूरी है. सर्जरी में आप 2-3 मंथ्स के बाद वो प्रेग्नेंट हो सकती है, एंड मेडिकेशन में ऐसा कोई मसला नहीं है. Number one, we should understand that treating Graves' disease with ATD, we should limit exposure to anti-thyroid drugs, particularly during the first trimester, during the 7 to 12 weeks of gestation are very important for organogenesis. That's why उस वक्त अगर कोशिश की जाए कि कम से कम या बंद की जाए तो बेहतर है. लिमिट एक्सपोजर 3 तरीकों से हो सकता है, या तो प्री कंसेप्शन डेफिनेटिव ट्रीटमेंट करें इन द फॉर्म ऑफ आरएआई और सर्जरी, या फिर पीटीयू और न्यूमरकोजोल को हम टाइट्रेट कम से कम रखें, और जो उनका हम T4 और TSH करवा रहे हो वो इस तरह कुछ रखे कि थोड़ा सा TSH लोअर लिमिट में हो, T4 अपर लिमिट में हो. इतना कम से कम डोज के ऊपर हम वो फर्स्ट ट्राइमेस्टर गुजार सके. So disease control with low dose and consider stopping it अगर किसी का जो है वो बहुत ही कम चल रहा हो डोज. So this is from the guideline, ATA guideline, कि consider discontinuation of ATD as soon as the pregnancy is confirmed if a patient is euthyroid on numercazole less than 10 mg, या फिर आपने PTU शुरू किया और वो लेस देन 100 mg पर डे के ऊपर हो, कोई गोइटर भी ना हो और ट्रैप भी आपने चेक किया वो भी नॉर्मल है, तो फिर ऐसे मरीजों में यू शुड स्टॉप, यू शुड डिसकंटिन्यू, एंड देन 2 वीक्स के बाद वापस बुलाकर दोबारा से थायराइड फंक्शन पे नजर रखी जाए. तो ऐसे में जितना टाइम गुजर सकता है वो गुजार लेते हैं ताकि टेराटोजेनिसिटी से बचा जाए. ATD in pregnancy, PTU is the preferred through 16 weeks of pregnancy, और अगर उसके बाद required हो then we change it into numercazole. TRAP testing is very important in the initial visit, then we repeat it in the 18 to 22 weeks अगर पहला वाला 3 times upper limit से ज़्यादा हो, और अगर अभी भी ज़्यादा है तो फिर we have to repeat it again at 30 to 34 weeks and alert the maternal-fetal unit. Okay, so just a summary, hyperthyroidism in pregnancy is the most common cause is Graves' disease, but we should also consider transient gestational thyrotoxicosis in the differential. 0.2% of pregnancies have hyperthyroidism. The symptoms are obviously absence of weight gain, which is like weight loss, anxiety, palpitation, heat intolerance. Remember, heat intolerance can be normal in pregnancy. Hyperthyroidism diagnosis, we should not be based on solely on low TSH. So we should also see the symptoms and elevated T4 as well. सिर्फ TSH तो हमें पता है कि वो कम होगा. एंड माइंड यू कि 10 मरीज जो आपके पास TSH कम के साथ आते हैं उसमें एक ग्रेव्स डिजीज निकलेगा. बाकी जो 9 है या तो वो फिजियोलॉजिकल लो TSH होंगे या फिर उनको जेस्टेशनल थायरोटॉक्सिकोसिस होगा. सो बी वेरी विजिलेंट. T4 भी करवाएंगे और वो T4 भी अपर लिमिट के 1.5 से ज्यादा होगा. तब भी फिर हमें नेक्स्ट ये देखना होगा, इज इट जेस्टेशनल थायरोटॉक्सिकोसिस और इज इट रियल ग्रेव्स डिजीज. So risks to pregnancy, we talked about it. Fetal or infant के IUGR, small for gestational age, pregnancy loss, और maternal के जो है heart failure और thyroid storm है. So pre-pregnancy planning was very important. मैं बार बार ये बता रहा हूँ. So we should go for the RAI versus surgery. Drug treatment in pregnancy, do not treat based on the lab alone. बार बार एक चीज repeat हो रही है. Treat for symptoms or pregnancy issues. Antithyroid can be used in pregnancy. Use the lowest possible dose to achieve improvement in symptoms. Goal is not to normalize the TSH, but aim for a bit थोड़ा सा upper वाला T4 and थोड़ा सा कम TSH. ये हमारा aim होना चाहिए. ठीक है जी. Now ATD में हमें ये बात बार बार कर ली है कि फर्स्ट ट्राइमेस्टर में PTU up till 16 weeks, देन उसके बाद जो है वो न्यूमरकाजोल. ये एम जो मैंने बताया कि हमारा एम होना चाहिए हाई नॉर्मल और हाई T4, बिकॉज उस वक्त फीटल थायराइड स्टेटस जो है वो नॉर्मल होगा. इफ वी एम फॉर अ नॉर्मल TSH एंड नॉर्मल T4 तो उसमें फीटस का 50% चांस है कि वो हाइपोथायराइड हो जाए. और अगर हमने न्यूमरकाजोल या PTU इतना ज्यादा दिया कि उसने T4 को कम करवा दिया, तो उसकी वजह से फीटस का हाइपोथायराइड तो 100% होगा. We talked about the tribe as well. So counsel all women as to options for control during pregnancy. Number 1, RAI, surgery, ATD. जितने भी पेशेंट्स हमारे पास आते हैं जो प्रेगनेंसी से पहले आ जाते हैं, so we should talk about these 3 options. एंटी थायराइड क्रॉस करता है, दोनों क्रॉस करते हैं, दोनों बर्थ डिफेक्ट्स कॉज कर सकते हैं, बट लेसर इवल जो है वो PTU है फॉर द फर्स्ट ट्राइमेस्टर. वन मोर थिंग इज दैट फर्स्ट ट्राइमेस्टर में ग्रेव्स डिजीज, ऑटो इम्यून डिजीजेस वो बहुत बढ़ जाते हैं और सेकंड थर्ड में वो इंप्रूव हो जाते हैं. पोस्टपार्टम में वापस जितने भी ऑटो इम्यून डिजीजेस इंक्लूडिंग द ग्रेव्स वापस जो है वो बढ़ जाता है. Antithyroid drugs can be used in lactation. You can go for the maximum of 20 mg per day of MMI, which equals to around 30 to 40 mg of numercazole. So you can use numercazole in lactation. So in conclusion, use pregnancy specific ranges. If not available, तो आप at least उसको जिस तरह मैंने बार बार बताया कि T4 को 1.5 से multiply कर ले. Differentiate between Graves and gestational thyrotoxicosis in early gestation. जाहिर है ये सेकंड ट्राइमेस्टर में अगर हमारे पास कोई पेशेंट आ रहा हो तो वो तो जेस्टेशनल थायरोटॉक्सिकोसिस नहीं हो सकता. प्री कंसेप्शन काउंसलिंग वाज वेरी इंपॉर्टेंट एंड कंसिडर मैटरनल एंड फीटल इफेक्ट्स ऑफ थेरेपी. लेट्स स्विच गियर्स टू हाइपोथायरॉयडिज्म इन प्रेगनेंसी. हाइपोथायरॉयडिज्म का डायग्नोसिस, वी नो दैट TSH के नॉर्मल रेंजेस 0.1 टू 4.0 है. सो किसी का भी TSH ज्यादा हो जाना और फ्री T4 कम या T4 कम हो जाना, this is the definition of overt hypothyroidism. मगर अगर T4 नॉर्मल है और सिर्फ TSH elevated है, more than 4 है, this is subclinical hypothyroidism. So hypothyroidism is more common, 2 to 10% of pregnancies. Universal screening is not recommended. It all depends on the symptoms or on the comorbidities that we do the TSH in a patient. So diagnosis made by elevated TSH. After elevated TSH, you go for the total T4 only. You don't do T3 in a hypothyroid case. You may also do anti-TPO antibodies to help you. Subclinical hypothyroidism obviously has effects on the fetus and on maternal fetus, low birth weight, pregnancy loss, IQ issues, and premature birth. In maternal, there will be increased risk of preeclampsia and gestational hypertension. Here again, you can see subclinical hypo means TSH is raised, T4 is normal. Overt hypo means TSH is raised and T4 is low. Subclinical is very common as compared to overt. Overt will occur in 1 in 500 and subclinical 1 in 50 women. Effects we know: gestational hypertension, pregnancy loss, prematurity, low IQ, low birth weight. Again, pregnancy complications and fetal complications. So subclinical के issues तो हमें समझ आ जाते हैं कि there all the studies, these meta analyses have shown कि pregnancy loss, preterm delivery, placental abruption सब कुछ है. So when we see the combined effect of subclinical and anti-thyroid autoimmunity, और ये दोनों मिल जाए तो फिर ये बढ़ जाता है, ये multiply हो जाता है. For example, if someone has a TSH of 5 to 10 and antibody positive, the odds ratio will be 9.5. While the same case 5 का TSH से लेकर 10 तक हो और antibodies negative हो तो the odds ratio will be 3.4. This is very important to remember. अगर ये दोनों चीजें मिल जाए तो फिर issues, miscarriages और जितने भी fetal maternal issues है वो बढ़ जाते हैं. So the ATA guideline 2017 recommendation about subclinical hypothyroidism. One thing is very clear: overt hypothyroid, we obviously have to treat with full dose of thyroxine and then repeat the TSH after 1 month. Subclinical में किसको treat करना है? Number 1, anti-TPO antibody positive अगर हो और pregnancy specific reference ranges से ज्यादा हो. What was the pregnancy specific reference range of a TSH? 4. So 4 से ज्यादा TPO positive, we have to give levothyroxine. How much? 50 mcg once daily. Strong recommendation, number 1. अब अगर एंटी टीपीओ नेगेटिव हो और यही प्रेगनेंसी स्पेसिफिक रेंजेस से अगर ज्यादा हो, अपर लिमिट से ज्यादा हो, 4 से ज्यादा हो बट 10 से कम हो, बट एंटी टीपीओ नेगेटिव है, in that case it's not compulsory to give levothyroxine, but we do consider it because of the because एक benign सी drug है, so we should give that. But उसकी recommendation इतनी strong नहीं है because someone who has TPO negativity और subclinical range में है तो उसके इतने सारे side effects नहीं थे. As we just saw कि the odds ratio was 3.4 while यहाँ पर odds ratio is 9.5. तो इसलिए इनको treat करना ज़्यादा लाजमी है as compared to this. But in reality we will obviously treat anyone who has a TSH more than 4 and is pregnant. अगर पॉजिटिव एंटीबॉडीज होंगे तो फिर स्ट्रांगली रिकमेंड करेंगे कि ट्रीट होना चाहिए. 2 केसेस हो गए. एंटी टीपीओ नेगेटिव है मगर TSH 10 से ज्यादा है तो ऑब्वियसली वी हैव टू ट्रीट एंड देयर इज अ स्ट्रांग रिकमेंडेशन ऑफ इट. एंटी टीपीओ अगर किसी का पॉजिटिव है बट TSH इज नॉर्मल, 2.5 to 4 इज अ नॉर्मल TSH. ऐसे केसेस में वी यूज टू से कि कंसिडर करते हैं, बट नाउ द न्यू studies done, the tablet trial done has shown no benefit of treating just autoimmunity. It is just autoimmunity. Antibodies positive but TSH is normal range, 2.5 to 4 hai. You may treat if someone has a risk of miscarriage, but the data is not shown any benefit of treating it. So I think I'm not confusing anyone. So इसको हम दोबारा से रिवाइज करते हैं कि overt hypothyroid we should treat. अगर 10 से ज्यादा हो, यहाँ पर ये दोबारा से ये बड़ा अच्छा लिखा हुआ है कि 10 से ज्यादा we treat it regardless of the antibodies. 10 और 4 के बीच में अगर हो, एंटीबॉडी पॉजिटिव हो, recommended, strong recommendation to treat it. बट अगर नेगेटिव एंटीबॉडीज हो और 4 और 10 के बीच में हो, so you may consider it, but strong recommendation नहीं है. Got it? 2.5 और 4 के बीच में हो, एंटीबॉडी नेगेटिव में तो बिल्कुल ट्रीट नहीं करते. एंटीबॉडी पॉजिटिव में यू मे कंसिडर, बट अगेन कोई खास बेनिफिट नहीं है एज प्रूवन बाय द टैबलेट ट्रायल. ओके, नाउ अ पेशेंट हु was known case of hypothyroidism was on thyroxine, and now because of the pregnancy the estrogen is increased and that has increased the TBG and this has led to increased demand of it. How to deal with it? There will be increased thyroxine requirement, and that increased thyroxine requirement is because of all these reasons कि TBG increase हो रहा है due to estrogen, T4 और T3 inactivate ज़्यादा हो रहा है by the placental deiodinase, volume of expansion बढ़ रही है, volume expansion हो रही है तो there will be increased volume of T4 distribution and minimal transfer भी हो रहा है बच्चे को. सो LT4 ट्रीटमेंट, पहली बात तो ये कि थायरोक्सिन सेफ है, यस इट इज वेरी सेफ, ना देना ज्यादा अनसेफ बात है, तो पहला क्वेश्चन पेशेंट यही पूछते हैं। LT4 डोज चेंजेस इस तरह है कि हाइपोथायरॉइड patients T4 should be increased by 25 to 30% as soon as the pregnancy is confirmed. Now, if a patient is on one tablet per day for 7 days, the patient is on 7 tablets per week. So you just have to increase to 9. That means Saturday, Sunday को एक गोली एक्स्ट्रा. दिस इज वन वे. और TSH 4 हफ्ते बाद रिपीट करवाना है, या फिर आप कैलकुलेट भी कर लेंगे. तो 7 tablets पर वीक है, हमने 25 to 30% बढ़ाना है, तो वो बेसिकली बनते हैं 9 tablets पर वीक. और 9 tablets पर वीक में जो है वो सैटरडे संडे अगर आप एडिशनल दवाइयाँ दे देंगे तो सही रहेगा. Once you start a patient on thyroxine, whether the patient was already on thyroxine और आप अभी उसका डोज बढ़ा रहे हो या फिर सब क्लिनिकल को आप ट्रीट कर रहे हो, when we start thyroxine, the TSH range will be, the TSH goal will be less than 2.5. देखिए पहली बात जो हमने की थी वो TSH नॉर्मल का रेंज 0.1 से 4.0, ये नॉर्मल का रेंज है. बट जब हम हाइपोथायरॉइड किसी को कह रहे हैं या सब क्लिनिकल कह रहे हैं और किसी वजह से स्टार्ट कर रहे हैं ट्रीटमेंट, तो अवर गोल ऑफ ट्रीटमेंट शुड बी कि TSH को 2.5 से फिर कम रखे. ठीक है जी. सो aim for a TSH less than 2.5 at conception. Check TSH as soon as pregnancy test is positive. रिक्वायरमेंट शुरू में 25 to 30% बढ़ेंगे, बट आगे और भी बढ़ सकते हैं. और जो ही पोस्टमार्टम हो जाए तो फिर प्री प्रेगनेंसी डोज पे वापस जाना है. ठीक है जी. So increase in T4 requirement occur as early as 4 to 6 weeks gestation and increases through the mid gestation. So this increase was due to increased TBG, increased volume of expansion, T4 का ट्रांसफर हो जाना और increased deactivation होना. So postpartum management following delivery, thyroxine should be reduced to the patient's preconception dose और फिर उसके 4 to 6 weeks बाद दोबारा से आप TSH repeat करवाएंगे. Someone who was subclinical and was just on less than 50 mcg dose, you can just stop thyroxine and repeat the TSH in 6 weeks. The last is about thyroid autoimmunity. In autoimmunity, we know that this is associated with higher miscarriage risk and higher preterm deliveries, and but the treatment does not show any difference in miscarriage, placental abruption, stillbirth. And this is the tablet trial, which again has not shown any significant difference between the thyroxine treated group and the control group in someone who was just antibody positive and the patient was euthyroid. Remember this thing. So in the 2017 guideline, we used to say that there is insufficient evidence to conclusively determine whether levothyroxine therapy decreases miscarriage risk in anti-TPO positive euthyroid women. उस वक्त हम ये सोचते थे कि administration of levothyroxine to TPO antibody positive euthyroid women with a prior history of miscarriage may be considered, given its potential benefit and minimal risk. तो उन केसेस में जितने भी हमारे पास आसान लफ्जों में बताऊं एंटी टीपीओ पॉजिटिव यूथायरॉइड आते थे तो वी यूज्ड टू गिव थायरोक्सिन. मगर अब जब टैबलेट ट्रायल आया और उसमें कोई खास बेनिफिट नहीं था, तो इसलिए इस देने का कोई खास फायदा नहीं है. इट विल जस्ट बी ओवर ट्रीटमेंट. बट अगर आप दे भी रहे तो पेशेंट को समझाना जरूरी है कि एंटीबॉडी पॉजिटिव यूथायरॉइड में थायरोक्सिन का बहुत ज्यादा फायदा नहीं है, प्रूवन नहीं है एटलीस्ट. So therefore, वो उनकी एक्सपेक्टेशन भी इतनी नहीं होनी चाहिए इससे. Yes, if the patient has more than 4 का TSH और फिर एंटीबॉडी पॉजिटिव है, then इसका फायदा होगा. So the last concluding slide, adverse effects of hypothyroidism on pregnancy and child neurodevelopment. Overt hypothyroid always requires treatment. So consider treatment of subclinical depending on the TSH level and TPO antibody status. Treatment जब एक बार start किया तो TSH should be less than 2.5. So thank you so much.